Thank you so much. So I'm Xiaoyan Wang. Right now, I'm the chief scientist at Intelligent Medical Object, IMO. So I'm leading the team driving the transformation from the healthcare ends to the life science ends. Thank you. I'm fortunate enough to spanning from academic medical centers to the real-world industrial settings. Right now, in the company of IMO, we actually focus on 3 levels of applying large language models or generative AI in our work. The first thing we do is we build a biomedical specific semantic large language models from those generic ones. What we do is we apply our knowledge built in terminologies into the model. Thinking about model building, there are 3 aspects there. One is the data, the other is AI technology itself, the third one is knowledge. So the richness of knowledge is extremely important in building about specific models. Give you an example, using the disease as liver dystrophy, which is a disease, have 2 forms. One is the acquired version, which is caused by environmental factors. The other is the form caused by genetic mutations. There are 9 different biomarkers, genetic biomarkers related to the disease. Our terminology actually code those specific biomarkers granular enough to capture each specific mutation causes the disease. Applying those knowledge into the data and using our technology can build a very rich data source for all kinds of medical applications. That's the first thing we do. The second thing we do is we apply the model into the healthcare setting, particularly in the provider setting. Help physicians document clinical notes more accurately, faster, and effectively. So that's the second thing we do. The third thing we do is we transform all the data, knowledge learned from healthcare into life science ends, and really to see how the knowledge and technology can support drug development and also approved drug from FDA. Also, we support a lot of solutions there as well. So those are the 3 things we do in our current company. So there are 2 things you got to do if you want to use generative AI in your work, in your applications. The first thing to do is to trust science, because you have to really follow up the advancement of technology itself to really understand its strengths and its limitations, because there are a lot of different maturity in different user cases. You have to really trust science and how advanced in your particular user domains. That's the first thing. The second thing you need to do is to be brave. You really have to test it, to really use it. If you don't, you hesitate to apply those technologies in your work settings, you're going to be replaced by someone who is using it. Thank you so much for the question. There are really 3 things you do. The first thing you do is to really understand the user cases, user scenarios you are actually building the applications for. Not only itself, but also the upstream and downstream of your applications. Really understand what's needed in that specific scenario. That's the first thing. The second thing is explore it, validate it in a real use case scenario other than hypothetical ones. Because I've seen across so many years, I've seen so many people building something just based on they think is important for people to use. Not really the people who uses it think that way. So build the cases particularly target on the users you are really using for. So the third thing is really keep, as I mentioned earlier, keep the advance of the technology, because maybe some problem you are struggling for 3 months is some other people already solved it. Really keep advance of the technology itself. Those are 3 areas, I think. It's a very nice question. I think that from 2 different levels. The first level, starting from one institution itself, within one clinical setting, for example, how we really connect the data, different structures. One is those tabular data, structured data, almost ready to use. The other is those unstructured data, which existed in clinical documentations, imaging, voices. 80% of clinical information existed only in unstructured data. So the first thing we need to do within those one clinical settings, integrate both structured and unstructured into one form. That is the connectivity we need to reach. The second one is across different health sets, across different organizations. You really want your data be able to talk to another institutions, which is probably 300 or thousands miles away. So we want to ensure the data interoperability across different settings. I think in the scientific community, for last 2 decades, there are different efforts on this. The thing we call the common data model. We really want to call the same term, the same disease, the same thing coded with the same standard terminologies to ensure data are interoperable across different organizations. So we can really holistically analyze data across different populations, different organizations. There are a lot of those we can talk. I can start from real disease user cases. For example, a lot of diseases extremely rare. They probably just, totally in the United States, we have 2,000 patients. Maybe one institution you only have 5 patients, the other have 10 patients. It's very hard to truly understand what's going on, how the disease is really triggered for or screened for diagnosis or confirmed for diagnosis and then being treated, how the disease progressed, how well the current treatment is. So with a very small sample now, with all the interoperability happening across different health settings, you can, not easily, but you can at least build hundreds or even thousands of those cohorts, really study them systematically, understand the disease landscape a lot better than one single institution. I think that is, a lot of evidence generation can happen within that setting if we have our data be able to talk to each other. So I kind of touched that earlier on unstructured data, which are in form of voice or image or clinical text. So I can start to talk about clinical text, clinical notes. I think a generative AI can help the physicians really document and write the notes or summarize the notes for that. And also the other thing is the voice. Nowadays, maybe you don't need to have to write it at all. So you could just talk to the machine to say, okay, here's a patient with whatever disease and here's my treatment, and then everything is automatically documented. Or you can record all the conversations happened between you and your patient, and so everything is very well documented. I think those are really becoming realistic now with the generative AI technologies. So there are lots of things can drive there in terms of the efficiency. For example, there are a lot of data behind healthcare systems. To give you an example, using Epic as an example, if the patient is being seen by a doctor and then transformed to a different clinical setting, every step of those caring process is documented in the tables behind EHRs. So their Epic has 18,000 table behind it, document all those processes. So there's a huge amount of data. Now with the technologies such as natural language processing, NLP, such as generative AI, we can integrate all those data at one site a lot more efficiently, accurately for people to use in both clinical care settings and also research settings and even education settings. In the clinical decision areas, I think there are two things you can do. As I mentioned earlier, it can help physicians document all the notes and summarize all those notes together with the most updated knowledge. For example, if the physician seeing the patient with diabetes, if we can really showcase all the related symptoms, lab tests needed for diagnosis and treatment of the disease at his hands, so it's a lot easier for him to really make the right diagnosis for the patient, make the right decision to treat the patients. That's one thing. On the life science end, it helps if we have a lot of data can support clinical trial decision making, can help FDA to get every evidence synthesized in one particular place and then to approve the drug. Because right now, drug process is really happens like you start with about 10,000 molecular compounds, then maybe 5 of them be able to make to the clinical trial space. A clinical trial take about 10 to 15 years to complete. It's really a long process. Generative AI technologies really can help those things to get more quality data to support those decision making, and also to get it faster, to get it reduce the cost as well. I want to focus on the faster space a little bit because I really learned the lessons about doing the research in clinical trial domains, which is time is life. To a friend of mine who actually is a clinician helping oncology patients, he has a patient with a rare form of oncology. There was a drug actually in the phase 3 trial. It's ready to be approved, but not really. So she's been waiting, and unfortunately he was not able to get the treatment because it takes another 5 years to the finish line. So that's really speed is extremely important in those settings because time is life. Also, I think you're asking me to predict the future of generative AI, which is a hard thing. I can start on the healthcare ends. I think the progress in healthcare ends is probably a little bit slower because every second you're dealing with a patient, a real life. You don't want to make any mistakes on that. So I think it's going to be slow on that end. But still, you can see generative AI can help on note-taking, reduce documentation burdens for physicians, and help to get earlier diagnosis if we have the most updated technologies. On the life science end, I think it's progress probably a lot quicker because we actually do a lot of research in the clinical trial optimization using AI. We actually just published a paper on that. I actually was interviewed by New Yorker on that as well. AI can actually accelerate clinical trials much faster nowadays. So in the life science end, I can see it progresses a lot of dimensions, such as we can really help selection of the compound from 10,000 to 5 in a much faster space, and also clinical trial can be reduced probably half of the time in next 5 years probably. Again, it's very hard to predict the future. I think the best way of predicting future is to create it. That's what we are doing now.